All right. Thanks to all those that have preceded me. It's a tall it's a tall bill. I'm going to talk to you about pharmacologic standard of care for COVID-19 in patients. Next slide, please, Holly. These are my disclosures. Next slide, please. So the focus of treatment for outpatients and generally speaking, those who are earlier on in their disease are really primarily focused on the virus. So either antivirals or monoclonal antibodies that are going to stop the virus from replicating in our bodies. And of course, the best treatment is prevention, and so vaccination. So having your own endogenous antibodies is of course highly important. And I think, by the way, I'll just mention that we all know from the trials, but I think that has really been highlighted with the huge surges of cases that we're seeing across all of Canada. For example, in Ontario, we're estimating 15 to 20,000 cases a day. Yet our hospitals aren't overwhelmed with COVID inpatients, and perhaps Omicron and BA2 cause less severe illness, but the sheer number of them, we would have expected many more hospitalizations if it wasn't for a very well immunized population. And so I think the most important thing that we can all be doing is preventing patients from coming into hospital and encouraging our patients to become vaccinated, and importantly to get boosted if they haven't. So I was saying the pharmacology, the treatment up front is really focused on the virus itself, and to an extent that's also true for inpatients, particularly when they're earlier on in the disease. But as you'll see, the secondary effects of the virus, namely the huge inflammatory response that it brings on in our bodies, is also part of the focus for inpatients. So the pharmacologic standard of care for inpatients includes antiviral medication, in particular Remdesivir for a smaller group of patients who are less sick actually. And then beyond that, we're really focusing on anti-inflammatory pathways with Dexamethasone, with anti-IL-6 antibodies, and anticoagulation. Next slide, please. So we'll talk about each of these therapies in turn briefly. It was recognized early in the pandemic that the systemic inflammatory response to this virus plays a huge pathogenic role in why people get sick. And so what do we have in our armamentarium to treat inflammation that's readily available, cheap? Well, steroids. And so people started giving patients with COVID steroids pretty early on in the disease, and we've known for quite some time from good clinical trials that they're highly effective. So Dexamethasone has become the standard of care for all patients who are admitted to hospital with COVID and are on oxygen. On the basis of this trial that was published relatively early in the pandemic. There were about 6,000 patients that were randomized to Dexamethasone or usual care, and usual care really meaning oxygen, ventilation. And it was seen pretty early, and it was seen rapidly that in this population of admitted patients, Dexamethasone indeed prevented death. There were some important subgroups in this trial, and it really spoke to how sick the patients were. The effect of Dexamethasone was amplified the sicker you were. So if you were intubated and ventilated, the relative risk of preventing death was the highest, 0.64. If you were on oxygen only by any delivery means, the relative risk of death, if you got Dexamethasone or didn't, was 0.82. But interestingly, if you were admitted to hospital but not on oxygen for whatever reason, and by the way, that's very common now. Lots of patients coming into hospital with COVID, as Dr. Lang was suggesting, but not on oxygen. So the elderly individual with fever, weakness, falls, delirium because of COVID, not with COVID, but I would say because of COVID, but not on oxygen because they've been vaccinated. that individual would actually not benefit from dexamethasone therapy. And there was a suggestion of harm with dexamethasone therapy in the individuals who were not on oxygen. In the entirety of this trial, the relative risk of death if you got dexamethasone and had COVID was 0.83. Next slide, please. So within these subgroups, there was a mortality benefit for ICU patients, and there were fewer days on the ventilator. On the ward patients, there was a mortality benefit, and there was a suggestion of prevention of escalation of care to requiring a ventilator. As mentioned, there was no benefit and perhaps a suggestion of harm in patients who are not on oxygen, so we don't use it for outpatients who aren't on oxygen and inpatients who aren't on oxygen. In the entire group, the number needed to treat was only 35 to prevent one person from dying, and it was even higher in the oxygen requiring cohorts. The dose of the medication is 6 milligrams a day for 10 days or until discharge, and the cost of it is $6.60 if it's given orally and $91 if it's given by IV. So a highly effective, relatively safe, and readily available treatment that all patients with COVID on oxygen receive. Next slide, please. We've already spoken about Remdesivir, and the data for Remdesivir, in my opinion, is strongest in outpatients who are not on oxygen and who are presenting early in their disease course. There's also evidence that, and Dr. Mertz talked about that data. There's also evidence that Remdesivir is effective in hospitalized patients as well, but unlike dexamethasone, where the sicker patients benefited most from the drug, it was the opposite with Remdesivir, where the least sick patients benefited most from Remdesivir. And I think that's because Remdesivir, being an antiviral, is most effective in the viral state of illness rather than in the targeting the host response. And by the time you're in the hospital on oxygen with COVID-related pneumonia, the biggest bang for your buck seems to be in targeting the inflammatory response, the host response to the illness. So in individuals who were not ventilated, less sick, Remdesivir seemed to prevent death, although the 95% confidence interval just passed the line of unity. That's kind of high. That's highlighted here in yellow under lower risk strata with no ventilation. And in the higher risk patients, so individuals who were ventilated or on high flow nasal cannula, those individuals did not benefit from Remdesivir therapy. Next slide, please. So what is Remdesivir? It's a nucleoside analog, and so RNA polymerase picks it up, but then RNA polymerase can't continue replicating the viral genome, so it stops viral replication. As mentioned, there's no benefit in those who are critically unwell. In the meta-analysis that I demonstrated on the previous slide, with individuals who are hospitalized requiring oxygen, there was no benefit regarding mortality or intubation, although the 95% confidence interval was right there. It may reduce time to recovery, but there's no change in length of stay. There's really no significant toxicity to the medication. Assuming the relative risk was significant, and I think it probably was, particularly on the basis of more recent data in outpatients, the overall number needed to treat was 143 to prevent one death. It's only given by IV, and it's given 200 milligrams on the first day and 100 milligrams daily for 4 subsequent days, and it costs $3,100 for a 5-day course. But I think Remdesivir, we do use it for inpatients who are mildly unwell, requiring oxygen by nasal cannula. And I think that biggest bang for your buck with this drug is probably in the outpatient space, or those who are less sick. Next slide, please. So really targeting the host response. Now we're looking at a medication called Tocilizumab. It's an IL-6 inhibitor. It's used for rheumatologic conditions. It's also used to treat patients receiving CAR T-cell therapy and complications therein. But as an anti-inflammatory medication, it's been found to be useful in patients, particularly with severe COVID. So this is, I think, the best trial of the drug. It looked at about 4,000 patients, all of whom were quite significantly unwell, elevated CRPs, on lots of oxygen, most typically high flow. And these patients were randomized to tocilizumab or usual care. Interestingly, at this point, when this trial was done, usual care did not always include dexamethasone, although often did. And so what was found in this trial was that the individuals who received tocilizumab were less likely to die, with a hazard ratio of 0.86, and that's highlighted at the bottom in yellow. Interestingly, when given to patients who did not get concomitant dexamethasone, the treatment effect was lost, evidence of harm, and so we always give tocilizumab with dexamethasone. And in fact, as mentioned, all patients with severe COVID, with COVID on oxygen, would get dexamethasone almost, I would say, without exception. And that's certainly true for patients who are getting tocilizumab as well. Excuse me. Next slide, please. So as an anti-IL-6 antibody, it targets the inflammatory cascade and inhibits cytokine storm. The largest study that I just showed a reduction in death and a reduction in the need for mechanical ventilation. There's a reduction in the need for dialysis. We give it to 25 people to prevent one person from dying. It's given 8 milligrams per kilogram in a single IV dose, and in times of drug shortages, which we actually had in Ontario just this past January, we were giving 400 milligram doses times 1, and it costs around $1,000. Excuse me. Next slide, please. In times of extreme drug shortages, which we also experienced not too long ago here in Ontario, there was no tocilizumab left. And so baricitinib, which is another immune inhibitor, has been tested in this kind of situation as well. This is a meta-analysis done by the Ontario Science Table, looking at the 3 largest trials for baricitinib in critically unwell patients with COVID-19, and the hazard ratio for death was 0.64 in individuals who receive this drug versus individuals who receive standard care. Next slide, please. And so this, baricitinib is a JAK1 and JAK2 inhibitor, and so through that mechanism reduces cytokine storm, and there may be some direct antiviral effects to the medication as well, although that's probably much less important, as I've alluded to already, when somebody is this unwell. There are lots of studies of the drug. There's some conflicting results, but it seems that in individuals who are more severely unwell, these medications seem to work better. As mentioned, the Ontario Science Table meta-analysis confirms a mortality reduction and a quicker recovery at 2 weeks. You treat 33 people to prevent one person from dying. It's given orally, 4 milligrams a day for 14 days or until discharge, and it costs around $1,400. When there's a choice between tocilizumab or baricitinib, in Ontario, the preference is to use tocilizumab, I think, because the data is somewhat more robust and strong. But in times of tocilizumab shortage, baricitinib can be given in its stead. Of note, both are not to be used, and of course, the selection is based on local availability. Next slide, please. So we couldn't talk about COVID-19, especially not a talk that's being put together by Thrombosis Canada, without at least mentioning venous thromboembolism. As you know, COVID-19 is a prothrombotic state, probably related to the cytokine storm that it induces. And so what are the rates of VT with COVID-19? It's hard to define in outpatients, mostly because we don't know the size of the denominator, especially right now when we're not testing. But in previous estimates, it's been thought that the rate of venous thromboembolism, DVT, and PE in outpatients with COVID-19 is around perhaps 1 in 100, maybe a little bit less. In ward inpatients, it's 4 or 5 in 100, and in ICU patients, even higher, 5 to 10 per 100. Next slide, please. And so these observations of excess VTE than what we would otherwise expect with similar like illnesses, for example, influenza, pneumonia, led a lot of interest to investigating anticoagulants as potential treatments for COVID-19. And this slide's actually a little bit cut off the way it's been presented, but there have been in hospitalized patients 33 trials done in ICU patients and 50 trials done in non-ICU patients. And I'm going to highlight a couple of them. Next slide, please. So the multi-platform RCT is really, I think, the largest trial in the matter, and shows the most robust evidence. It broke patients down into ICU type care, being intubated, ventilated, or receiving high flow oxygen, and the non-ICU patient population receiving low flow oxygen. And they asked the question: is therapeutic or prophylactic anticoagulation with low molecular weight heparin better or worse? And what was found in the multi-platform randomized controlled trial, was that in the intensive care unit, prophylactic anticoagulation was better, and on the wards, therapeutic anticoagulation was better. Next slide, please. And with that. Perhaps I'll just highlight. I did have a slide before on how these patients are treated. So I'll just highlight, briefly. Patient comes in, COVID-19 requiring oxygen. We would give them all dexamethasone. If they're on low flow oxygen, they'll also receive Remdesivir. If they deteriorate, despite that therapy, so need more oxygen, get more unwell by any measure, and assuming their inflammatory markers are elevated, we would then proceed to add a dose of Tocilizumab or baricitinib if there's a Tocilizumab shortage. These patients would also all receive therapeutic anticoagulation, assuming they're at relatively low bleeding risk. These patients would all receive prophylactic anticoagulation, as all hospitalized inpatients would. And if they're at low bleeding risk and they're on low flow oxygen with COVID-19, they would probably receive therapeutic anticoagulation. If they deteriorate further, and they move to the ICU or require high flow oxygen, then the therapeutic anticoagulation dose, then the dose of anticoagulant would be reduced to prophylactic.